Should we just mention about the relationship between our society and death? Do you think it's a dysfunctional relationship?
Yeah, I think that's a very good starting point, John. That, you know, we have sort of sanitized death over the centuries, and it's very separate often to how we live. And it didn't always used to be like that. You know, people used to keep somebody who had died at the home for a while, and people would come and view. And that when you see somebody who's died, who you love, you know, you get this sort of different view of death, and you sort of see that when somebody dies and their sort of spirit leaves them with that last breath, and you have this very, you know, a corpse isn't them, it's not them anymore, something's missing. And when you see that, you can sort of have a different view of what dying means, and also of what happens to us after death. But having made it very medicalized, people almost have a very protective instinct over a corpse. You know, we have a culture where post-mortems, for example, are often, people tread on eggshells around it because they're scared of upsetting family, and the number we do has reduced massively because of that idea that you have to be very respectful of a corpse. And I am. I'm not suggesting you shouldn't be, but there is a sort of pragmatic line where you say, actually, this isn't very good to anybody, this body anymore. It's not helping the person who was alive, they've gone. But there's information there that we could learn if we were to examine it more thoroughly and to do a post-mortem. And so that's the idea, the approach I've always taken to post-mortems, is that actually, you know, if you do study it and look and dissect it all very carefully, you can learn more that can help the people who are alive. And I think that's a really important thing to be doing. But we just don't do it very often. And that was a problem way before COVID times. But COVID made it worse. So the Coronavirus Act introduced different ways around death reporting that made it much easier for a doctor that didn't particularly know what had happened with a patient to still be able to do a death certificate if they sort of could. So that you don't have to know exactly everything about why someone died in order to write a death certificate. The GMC regulations say that you need to be able to do it to a doctor's, to the best of the doctor's knowledge and belief. So to the best of what I know and believe, this is why this person died. It doesn't even give you an obligation to go and discover everything that you could know. It's just based on what I do know, this is why they died. And you know what? That's sort of okay if you've got a system where everyone acknowledges that the purpose of a death certificate is not to give a definitive answer. And, you know, if people are saying, well, we have a death certificate system so that people get a broad view of why somebody died, and that we might get a sort of broad brush feel for public health issues, but we're not trying to diagnose death. And we took this system that was only really based on that and pretended it was accurately diagnosing death when it just couldn't.
I mean, just unpack a little bit, Claire, the difference. So you've got a GP who might waltz in and see a patient for 10 minutes a few times a day before they die, or even a hospital doctor who's only been with them for sometimes minutes or maybe just a day or two before they die. How much more, and you're a pathologist, you can actually do the post-mortem, you can look at the science, you can put it under the microscope. How much more accurate is your diagnosis as a pathologist than a clinical doctor's diagnosis?
So it very much depends on the situation. You know, sometimes the clinical doctors are better than us, right? There are occasions when some of the imaging techniques are so detailed and precise that they can show things that actually it's quite hard to show at dissection. So, you know, it's not like one's better than the other all the time. But when people have done studies where they've sort of deliberately done audits of what doctors and clinicians believed they knew, and they got consent from the relatives and said, well, actually, let's just check this at post-mortem, see if there's anything else that you missed. I can't remember the exact figures, but it was quite concerning that the confidence that doctors had based on what they, you know, the blood tests and the imaging was a little bit too high, and that there is absolutely room for doubt, and there is very much room for auditing so that doctors get feedback and learn and realize the limitations of what can be very, very impressive looking by way of testing, but actually isn't always perfect.
And of course, the whole nature of biomedical science is predicated on dissection, really, isn't it? I mean, going back to Henry Gray and Gray's Anatomy, and people that drew the pictures way back in, John Hunter and all these early pioneers. The reason we know what we know is because we can relate that to anatomy, and then relate that to physiology. And the only way you're going to know that is by, well, as you say, there's modern imaging techniques now, but it's all predicated on this basic dissection that is necessary. And I mean, I'll just comment on a couple of your points there, Claire. I didn't see a body till I was 18. So, you know, relatives died. I wasn't allowed to see the body. When I was 18, first year student psychiatric nurse, I actually remember the names of the first patients that died from all those years ago. And you do get that impression that the person is simply not there. Even in the minutes after death, that's there. And, you know, many times we've done a laying out procedure with junior student nurses, maybe 18, 19-year-old young people. And they say that they often, you know, they've often said, well, the person's not there, are they, John? You know, and we have this ludicrous tradition in nursing where you open the window to let the spirit out, which is, it's kind of quaint, but you know, it goes back for hundreds of years. But the point is that the person has left, and
yeah,
you know,
there's one thing that really struck me when I was writing the book, actually, which is a little bit of etymology. So the word expired is from that, you know, the Latin expirare and inspirare, and all of those words are related. But in Latin, expirare is expiration of the spirit. It's not just breath. And so spirit and breath are actually the same word originally. Yeah. And so the phrase to take your last breath, or your last breath leaving the body, if you were saying that in Latin, you would say the spirit left the body. And so, you know, that kind of really makes sense when you see it happen. And actually, my father died in October 2022, and I was with him when that happened. And there, you know, his last few breaths were quite, you know, he went very gradually, very peacefully, and they separated in time. And then the last breath left him, and his, you know, immediately his face is sunken, everything's, you know, he's doesn't look the same. He just didn't look the same. He had gone. Something had gone. And actually a little bit more etymology is the word autopsy, right? So the word autopsy means to see for yourself. And that is like so fundamental to science, is that the whole point of science is that you are very aware of when you're making assumptions, you know, which bits have got evidence and which bits is you sort of bridging the gaps, trying to make a picture, so that you're constantly trying to find out where you're wrong. And people lost that a little bit recently. And the reason that postmortems are so important, and the reason that, as you said, that medicine was built from dissection, is because you learn by constantly going back and looking at what the evidence shows, and then from there trying to make sense of the world. And that was really hammered into me when I was training to be a pathologist. And it wasn't just about autopsies, it's also about what you're looking at down the microscope. That you might find a few things, and you can very quickly jump from those few things to a diagnosis that would fit that pattern, and then you feel like you've done something and you've, you know, ticked a box. And I was always being dragged back and say, no, stop, keep looking, just keep looking until you've really absorbed everything that's there before you jump to any conclusions. And I think that's where everybody failed so badly on this one.
Mm-hmm. And it's such a protection for the public as well. It's like the coroner system in this country, you know, since Magna Carta, it's been a protection for the public. And you just get the feeling that level of protection, that if someone bumps me off, someone's going to find out about it. I just get the feeling I'm not as well protected as I was 5-6 years ago.
I think it's probably longer than that. So really, it has been a long time when we haven't been doing many postmortems. And to be fair, people did do postmortems on COVID patients, right? So the Royal College of Pathologists had an audit of around 40 detailed postmortems of people who died after a COVID diagnosis, and they were showing what this looked like, where the pathology was, you know, people. And so pathologists were doing this. But on the other hand, there were also pathology departments that just stopped doing autopsies altogether for the period. So, you know, there was a huge variation in what was going on. And as I said, the law changed, right? So prior, you'd have a doctor would have had to have seen a patient in life before being able to make a death certificate. But the Coronavirus Act said that they either had to have seen them in life or after death. Well, that's not telling you the full story, is it? Seeing a corpse after death, just literally just seeing it, is not enough to tell you why somebody died. And that was combined with a situation where we had people who were phoning up care homes and speaking to the staff there about why somebody had died, and that became the basis of the death certificate, which is not a thorough enough investigation. That's not how it should have been done.
No. And then that brings in all the other variables, like what medications they'd been given. Had they been given midazolam? Had they been given morphine?
Mm-hmm. Well, exactly.
So-called end-of-life drugs.
Yeah, and people were prescribing at a distance and then certifying at a distance. And there was no protection there for the people who potentially could have been, either neglected or harmed in some way.
I mean, I've talked to nurses working in care homes who have put their own phone by the patient's bed. The GP's made the diagnosis, prescribed end-of-life drugs based on a mobile phone conversation. It's just, to me, I just find it totally incredible that we could go so far away from the principles that we were trained on and that I trained student nurses on for all these years. That we could just ignore these principles of communication, which is fundamental to the healthcare relationship.